You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, host Tony Schueth, CEO of Point of Care Partners, is joined by colleagues and guests Mary Griskewicz, Regulatory Resource Center Lead, and Janice Reese, Senior Consultant and Program Manager of the FHIR at Scale Taskforce, or FAST. Together, they break down the HTI-5 and price transparency proposed rules released in mid-December 2025. They'll discuss their intent and potential impacts across the industry. They'll also explain why engaging in the comment process matters. We hope this episode offers fresh insight and inspiration to participate in the proposed rule comment process. Have ideas for future episodes? Visit POCP.com and choose podcast under the Insights section and submit a form to share your thoughts.
Welcome back to The Dish on Health IT. I'm Tony Schueth, Chief Executive Officer of Point of Care Partners. In mid-December 2025, two proposed rules dropped that could meaningfully shape how interoperability, transparency, and data access evolve over the next several years. One is the HTI-5 proposed rule from the Assistant Secretary for Technology Policy. The other is CMS's latest proposal on price transparency. We decided to bring together a couple of our POCP experts to discuss what these rules intend, how different stakeholders may be affected, potential unintended consequences, and why the upcoming comment periods matter more than people often assume. I'm joined today by two of my deeply respected colleagues who spend a lot of time in the details so others don't have to. Mary Griskewicz, our Regulatory Resource Center Lead, and Janice Reese, Senior Consultant and the Program Manager for the HL7 FHIR at Scale Taskforce, or FAST. Let's start with quick introductions. Mary, why don't you kick us off?
Hi, Tony. Thank you for having me today. As you stated, I serve as the Regulatory Resource Leader for Point of Care Partners, and I'm a Senior Consultant. I do spend my time in the weeds, Tony, reading all of the regulations that impact our clients and our customers to help them have insight as to how this potentially will impact them, their work, and their clients as well.
Janice, how about you?
I'm Janice Reese, and thank you so much, Tony, for having me today. I'm a senior consultant with Point of Care Partners, and I'm also the program manager for HL7's FHIR at Scale Taskforce, or FAST. And I focus on helping the industry operationalize trust, identity, security, consent, and interoperability at scale. Through my work at POCP, I also support healthcare organizations as they navigate regulatory change and real-world implementation challenges. And I'm also a volunteer with the Health Sector Coordinating Council Cybersecurity Working Group, where I contribute to strengthening cybersecurity and resilience across the healthcare sector.
And we're delighted to have you on our team. So before we get into HTI-5 and price transparency themselves, I want to level set a bit. Mary, for the listeners who don't live in the Federal Register like you do, can you briefly walk us through how proposed rules actually work, from publication to comments to what eventually becomes a final rule?
Sure, Tony. Let's start with the concept of what is the government trying to do. So there's typically some type of policy set, either by Congress or the administration. That administration then identifies how are they going to put those policies into action. Typically, they have authority then to either ask one of their agencies to come up with a rule. So they usually start with a proposed rule. Sometimes they'll even start with requests for information. When we get a proposed rule, it's usually based upon some either legislative or some type of executive order that's been placed out by the government. Once that's placed, we have 30 to 60 days, depending how technical the rule is, to provide our comment. Once that public comment period is done, what we'll then see is how the government will then have all of their folks review all of those comments and then determine what the next steps will be. That can actually have two results, or actually three. They can come up with an interim final rule, because they still want additional feedback, or they come up with a final rule. Sometimes they'll even halt, depending on the comments that they get from the private citizens in the United States. And I will say that every citizen in the United States has a right to provide public comment. And sometimes they'll wait and then come out with a new proposed rule, or they'll even ask for additional requests for information.
And they actually pay attention to those comments as well, don't they?
They review every single comment. Typically, what they do is they'll put them in sections. As you go through the Federal Register and you look at rules, there are sections. There are introductions, then there are the details, and there's usually a conclusion. A lot of times I start with the conclusion, then go to the top, and then go to the middle. They will take those sections, depending on how the comments come in, they'll group them, review them, and they do respond to every single one in one way or another based upon their final or their interim rule that they come out with.
Love that pro tip, right? Start from the end and then work backwards.
That's
Janice,
right.
is there anything you'd add since you've also participated in this process yourself over the years?
Yeah, I think the only thing I'd add is the comment period is really where the policy meets operational reality. And proposed rules, I think, are intentionally written at a high level. And CMS is really looking on concrete input on the feasibility, the sequencing, and what are the potential unintended consequences. And so I think that the most effective comments aren't long, but they're very specific to how something would work or not, and what the industry can contribute on the recommendation of what they're trying to accomplish.
Well said and well observed. Mary, let's turn to HTI-5. Mary, at a high level, what's the government trying to accomplish with this proposed rule? What problem is it responding to?
A couple of things. So we all know that the exchange of health data is complicated. And we know that they have requested the vendors to certify either their EHR systems or their modules to exchange data. And they've put requirements for them on how to do that and what standards they should be doing. You know, the typical life cycle for a systems vendor, in particular the larger EHR companies, is usually like 18 months to come up with a new release. That is, from a life cycle methodology perspective, a rather long time when you're a client waiting for something at the other end. So what they actually do is they're looking at how do we make things quicker, faster, better? How do we give the relief? And what they really looked at here is how do we help the vendors exchange the information? As we know, system architecture has changed over time. And those mandates have been very cumbersome on the vendors. So they want to open the architecture by using new standards. And I know Janice is going to talk about this. And one of them is using FHIR, an open architecture to exchange the data and help that data get moved. And we want to do it quicker, faster, better in a quality manner that provides safe patient care, and while the data must be secure. The other thing that they were looking to do in this rule is look at how could we potentially expand with TEFCA over time. And will using the open architecture help us do that? And how do we help the market overall get to what we call scalable data exchange, while at the same time really looking at protecting the information and making sure that the information is not blocked. They do provide some clarification on exceptions for information blocking, in particular for the vendors. And this will help the industry set a new roadmap to make sure that the information that is exchanged is done in a fair manner, it's secure, and provides the patient care that we all deserve.
So Janice, she really set you up. She wanted you to talk about FHIR, but I'd love to have you talk about FAST as well, which is based on FHIR.
Sure. And I think my first reaction was that it's a clear signal from the government that we're moving from experimentation to execution, because HTI-5 does reinforce a FHIR first direction and reduces some of the certification complexity, but it also implicitly raises the bar, because if FHIR is the standard, then the work that FAST is working on with security, identity, and trust can't be optional or handled inconsistently anymore. From a FAST perspective, what stood out is that HTI-5 doesn't try to prescribe every technical detail around security and identity, but that's exactly where the real work needs to happen now. As data exchange becomes more API driven and more network to network, the industry needs shared implementable approaches to things like authentication, authorization, identity assurance, and consent. Those are all things that we're working on with the CMS Aligned Networks initiative. Otherwise, we risk faster interoperability that isn't scalable or, most importantly, trusted. And I think trust is the biggest word right now. So that's where FAST is very focused. Our work across security, identity, consent, and the National Directory is about operationalizing trust at scale. So organizations aren't each reinventing their own interpretation of what secure FHIR exchange means. And I think HTI-5 creates the policy and the regulatory space for that to happen. So FAST is helping the industry fill in the infrastructure and implementation layers so that these requirements can actually work in real-world multi-party environments in a trust track. How do we integrate those together and start to do things in a testing that validates the data across that API workflow? And I think that's critical for the future.
To be sure. To be sure. One of the more consequential changes in HTI-5 is how information blocking definitions are clarified to explicitly include automated and AI-driven access. What's the big deal, or is it? Mary, let's go with you first.
It's a really big deal, Tony. Automation, I'd like to say, is queen right now, right? How do we get data from point to point and to do that? HTI-5 doesn't change things from the perspective of we all want to exchange data, but it will give us the standards to use. And automation is the way to do that. And using the more current open architecture standards will actually get us to success. The big thing, as Janice said, is trust, right? Having that trust between all of our players in the ecosystem, or actors, as we call them, is really key. And getting that information from one place to another in a trusted environment is absolutely key and the most essential thing that we as patients want and expect, and we help our providers along the way to do that.
Janice, do you have a perspective on this?
Yeah, I do think it's a big deal, and maybe more for what it signals than for the words themselves, because they're explicitly calling out automated and AI-driven access and the information blocking definition, because HTI-5 is now acknowledging how data is being used today. Access decisions are no longer just about a human clicking a button. They're increasingly embedded in APIs and workflows and algorithms. That means organizations have to be much more intentional about how access is governed, not just whether an endpoint technically exists. So those are things from a FAST perspective that reinforces that you can't separate interoperability from trust. And I think trust is the key word as we go into 2026, because as access becomes more automated, the questions shift from can I get the data to should I get the data? Under what condition? And how do I prove that that decision was appropriate? That's where security, identity, and consent move from background requirements to the core infrastructure of having a healthy network that you can actually trust the endpoints, trust the communication, trust the process. And I think also FHIR APIs are no longer just about checking a certification box. They are becoming the primary way that data is accessed across networks by people and by systems, including consumers. So organizations that only implement the minimum are going to struggle as expectations increase around reliability, scalability, and most importantly, accountability. So what we see across the FHIR accelerators, especially in FAST, is a shift toward operational readiness. That's what CMS Aligned Networks wants to see happen. A lot more people on the network, a lot more data exchanged, but in a trusted, secure environment. So the focus is on how FHIR works in real multi-party environments, how identities are established, how trust is enforced, how consent travels with data, and how all of that is tested at scale. HTI-5 doesn't spell all of that out, but it creates the environment where doing this well is no longer optional.
Well said. Mary, is there anything from a policy lens that you'd like to reinforce or clarify?
I think one of the things is I think we'll see HTI-5 as the groundwork for HTI-6. ASTP, the National Coordinator of Information Technology, has been very, very clear that the health technology and information rules are not going to go away. As we continue to evolve, as technology continues to develop, we will have to keep pace. In order to do that, from a policy lens, we know that folks at HHS, CMS, and even some of the tri-agencies will continue to look at this, and we will be working with ASTP and our multi-stakeholder initiatives, as Janice said, FAST being one, HL7, Gravity, and there are many, many others that are all watching this. It will continue to evolve, and it's not going away, Tony.
Let's talk impacts by stakeholder group, starting with the HIT vendors and digital health companies. Janice, HTI-5 removes or pares back a significant portion of certification requirements. What does that free vendors up to do, and what responsibility shifts then back to them?
I think it definitely gives vendors more breathing room by pulling back some of the prescriptive certification requirements, but that should free them to invest less in check the box compliance and more in making FHIR actually work in some of the real world environments that we're discussing about better performance, stronger security, and more reliable interoperability. But at the same time, this also shifts the responsibility back to vendors. With fewer guardrails and certification, they can't point to compliance alone as proof they're interoperable or trustworthy. And I think as FHIR APIs become the primary way that data is accessed, vendors will be judged on how their systems operate at scale across networks with proper security, a foundation on identity and consent. So HTI-5 gives more flexibility, but I think it also raises the bar on accountability. And from a FAST perspective, this is where the industry needs the shared infrastructure and the implementation guidance that FAST has been working on since our founding and what we were originally set up as a tiger team inside of ONC. It gives vendors more freedom, but it also raises the bar on accountability. So the ones that lean into that will be better positioned as the ecosystem moves from pilot to scale and data and consumers and access all across the healthcare ecosystem.
Mary, are there risks here that vendors may be underestimating? For example, what might be coming in HTI-6 if these certification rollbacks stay in the final rule?
Tony, absolutely, there could be risks. I think the vendors in particular have to think of a couple of things. Number one, what is your overall compliance at all times? It is very important for you to remain compliant because you want to remain competitive. The second thing is, how does this impact your product workflow? As I said, it takes vendors a little bit of time, really, to switch gears. And it costs money in order to do so. So in order to remain competitive, in order to bring the best products out to market, you have to keep current. The big risk, though, here is we don't know what HTI-6 is going to be about. And ASTP, ONC has already said there will be one. So providing comments to HTI-5 is really critical to the industry. And I would say that it's really important for everyone to really focus on quality comments, not quantity comments. What does that mean? It really means looking at experience, making sure that you're providing examples with data and research. Specifically, your experience, whether you're a vendor organization or a trade organization, it is critical that you provide that and you lean in. And as I like to say, birds of a feather sometimes accomplish more. So work with your trade organizations, work with us at POCP. We're more than glad to help you. But again, focus really on that quality because you do not want to have HTI-6 come out or a final HTI-5 with constraints that will not give you the relief that you need and that put onerous compliance risks to your organization and or additional work. And we have seen that in the past. We've actually seen deregulation and we've had to see guidance on rules issued in order to give relief to the industry. And we really don't want to see that. We really want to go forward and provide our best foot forward with commenting.
Well said. I'm going to take my moderator hat off now for a second and sort of express my opinion. I do think there's risks that some vendors might underestimate what this shift really means. The rollback of certain certification requirements in HTI-5 can feel like relief in the short term, but it also removes a layer of protection vendors have relied on to demonstrate readiness. If the industry responds by treating this as a reason to do less rather than to mature their implementation, that gap will show up quickly. What's likely to follow is something like HTI-6 is not a return to the same checklist, but stronger expectations around outcomes. As FHIR APIs become the default and access becomes more automated, regulators will be looking for evidence that systems are secure, reliable, and interoperable in practice. That could mean more focus on testing, real-world performance, and network-level trust rather than static certification artifacts. So the risk for vendors is assuming this is deregulation in the traditional sense. It's really a shift from perspective, requirements to accountability. Vendors that invest now in solid security, identity, and interoperability foundations will be better positioned if and when the next phase tightens expectations around how these systems behave at scale. This also creates a collective risk for the ecosystem. A new entrant that cuts corners on security or identity may be technically compliant in the short term, but a single high-profile failure can undermine trust across the entire industry and invite a regulatory response that affects everyone. In that sense, strong network-level trust is not just a competitive advantage, it's a shared obligation to protect the credibility of interoperability at scale. So how will providers and health systems be impacted? If vendor certification changes occur, does this change anything for the health systems or practices that might be using technology solutions that have previously been deployed under the auspices of certain certification requirements? Janice, I'll direct this one to you first.
Yeah, I think for providers and health systems, HTI-5 doesn't mean the technology they're using today suddenly becomes non-compliant or unsafe, but it does change what certification represents going forward, because certification is no longer a guarantee that a system will interoperate well, securely, or at scale in real-world FHIR-based exchange, especially based on what you just mentioned in regards to the risk for the ecosystem if somebody comes in and cuts corners on security and all of a sudden the trust is eroded. So I think what shifts back to providers is the need to be more informed consumers of technology. Health systems will increasingly need to ask vendors how their products actually perform across networks. They have to agree upon how identity, access, and security are handled, and whether solutions work reliably beyond a single environment. And that's the efforts of what FAST has been working on with the infrastructure. So I think the upside is more flexibility and innovation. The trade-off is that trust and interoperability become things providers actively validate, not just assume because a product must meet because a product previously met prior certification requirements. So I think the validity of a trust track, which is what FAST is looking at as we go forward with HL7 and our connectathons, in how that combined identity, the foundation of security, the ability to map consent across multiple entities and manage that in more of a computable approach is what will change for the future in the validation.
Let's talk pairs. And Mary, let's start with you since you come to us from Cigna. It doesn't appear that HTI-5 changes pair prior authorization requirements directly, but it does reshape the data access environment. So how may health plans feel the implications of HTI-5, Mary?
You're right, Tony, it doesn't. And, we have heard some of the payers say that we can't exchange data in the new open architecture with the FHIR APIs. That changes things immensely. This opens up the architecture to use FHIR and the APIs to become the default data access. For health plans, this is really important because they're going to have to exchange using those APIs. It's more dynamic. It's thought of as automated workflows versus manual processes. That, again, it's time, it's money. If you can automate something and you can improve your processes, you are more efficient and effective, and you're able to get your solutions to market to keep your customers happy. That is critical. The implications have real concerns, though. As Janice said, you're looking at security, you're looking at quality and timeliness, getting that information from point to point so the providers can make those decisions for their patients is critical. When we look at identity and consent, as Janice said, because now it's automated, right? So there's less tolerance for failure, for ambiguity, mistakes, and inconsistency. So the payers are going to feel more pressure. They're going to feel that they have to operate in this environment of trusted interoperability. They have to work with the network overall, and they have to look at those one-off integrations. Those are going to be more competitive from the perspective of, if I could do this faster, quicker, better, and I would rather use that than a proprietary approach that doesn't play with the entire ecosystem. As we think through this, as Janice indicated, we have the networks. We also have TEFCA. What if in HTI-6, you asked me the question before, what potentially could this be for a risk? They have more mandates using TEFCA as a network. That's something to think about. In a sense, the HTI-5 really accelerates and shifts for plans for mandatory transactions to managing trust at scale. That is the key thing here. Trust between not just the payers, but the providers as well.
You're right, Mary. HTI-5 does change the environment payers are operating in. As FHIR APIs become the default for data access, health plans will be expected to exchange information more dynamically, more frequently, and often through automated workflows rather than manual processes. This has real implications. It raises expectations around data quality, timeliness, security, identity, and consent, because when access is automated, there's much less tolerance for inconsistency or ambiguity. Payers will feel increasing pressure to operate as part of trusted, interoperable networks rather than relying on one-off integrations or proprietary approaches. In that sense, HTI-5 accelerates a shift from plans from managing transactions to managing trust at scale. Janice, any final thoughts on HTI-5 before we move to price transparency?
Yeah, I think from a FAST perspective, the removal of specific privacy and security requirements in HTI-5 doesn't mean those issues are less important. I think it actually makes industry-led implementation more critical. FAST plans to use the comment period to reinforce that, while certification requirements may be pared back, but the need for consistent interoperability, security, identity, and consent practices has not gone away, especially in what you and Mary just mentioned around trust and the foundation and the consumer and the trust between the provider, the trust between the health plan, the trust between the complexity of that. So I think our comments are going to focus on clarifying that policy flexibility and hopefully not translated into fragmented or inconsistent security implementations, because we've had a lot of success with fast security so far, because when it's consistently, effectively used from the implementation guidance that FAST has provided, it's consistent with giving you a much less cyber attack threat environment because of some of the ways that we've been able to maximize that. We're currently surveying the industry for SGU3 to take that further and to tie that even tighter with identity in the variation of being able to work with the major identity providers, certified, providers to be able to be out there. So I think being able to have an exchange that becomes more automated and network to network, which is what we need. Privacy and security need to be addressed through the shared infrastructure, through implementation guidance and testing, not left to individual interpretation. That's where it really goes wrong. I think FAST right now is very well positioned to highlight how our industry developed guidance, specifically our security, identity, and consent is about to be balloted and have our official IG, can complement HTI-5 by providing those operational guardrails that certification no longer fully supplies. And this came up in the most recent Connectathon, where the discussion on directory and the network was, how do we actually test the health of the endpoint? and validate that as a part of a trust environment, as part of a trust network. So FAST is going to support the direction of HTI-5, but we're going to emphasize that trust doesn't disappear when requirements are removed. It has to be intentionally built and validated at scale. And I think that's going to be the foundation of some of our comments.
At this juncture, I wanted to acknowledge that this is usually where we bring in Vanessa Candelora. She's our subject matter expert on price transparency, and we really wish she could be with us here today. Unfortunately, schedules didn't line up, so we're going to cover this at a high level and focus on content rather than on deep operational detail. I want to spend a minute setting the stage. Price transparency has moved from a theoretical policy goal to an active compliance requirement. Hospitals and insurers are now required to publish pricing data, but the industry is still very much in a middle phase where compliance doesn't equal clarity. Even when organizations are technically compliant, pricing data is often buried in massive machine-readable files that are hard to interpret. More importantly, there's still a disconnect between the clinical language a patient hears and the billing codes used in pricing data. Patients are being given access to information that is technically accurate, but often difficult to use. With that as context, let's talk about the proposed rule. Mary, at a high level, what is CMS trying to do with the latest price transparency proposal?
Well, Tony, it's first of all a tri-agency rule. I want to make sure everybody understands that between the IRS, the Department of Labor, and HHS. So what they've done is they've actually bolstered and clarified in this rule from their initial rule and their final rule from 2020. What this rule does is it tries to provide clearer and more actionable, I would say, policy and standards around health pricing. You know, there are some members of Congress and those in policy that think health pricing should be as easy as buying a can of peas in the grocery store. So think of that. How do we make that transaction of health pricing simple and easy? That's what they're looking to do.
From your perspective, what are the most meaningful changes or clarifications in the proposal that stakeholders should be paying attention to?
I think there's a couple of things. Number one, and there's top three, and there's a couple of others, but looking at the machine readable files, the plans have had a heck of a time, to be honest with you, looking at how do we do this. It is expensive. It is, again, time consuming. How do we look at this to ensure that the metadata, right, by product type and the networks that are used and identified can actually be done quicker and better. And also the enrollment information, really. How do you do that? And then the reporting requirements are a little onerous right now today. So really looking at how to reduce those, make it a little bit easier for folks to report on, and then improving the standards overall. Again, everything is about standards on how to exchange the data. One of the reporting requirements example is really looking at those files, right? And looking at the allowed amounts and checking to make sure that they're going from monthly to quarterly, a little bit easier in reporting for the industry overall. I think allowing folks to look at how the files around the amount of information by market type is really important for the payers, and then reducing the claim threshold, right? So they're going from 11 to more claims, and they're increasing the reporting period from 3 months to 6 months. And then they have a look back period, which is nice. And that's going from 180 days to 9 months. So again, giving some relief to the plans. I think this is welcomed overall. It will be interesting to see what the comments come in at, but I do think that these are going to be positive changes to help us, again, exchange the information and get to the pricing information quicker.
That's encouraging. It'd be nice to know what services cost, for sure. Janice, stepping back from policy and looking at this from an infrastructure and standards perspective, what challenges still need to be addressed if price transparency is ever going to work in a more fundamental way?
I think it comes down, the core challenge is that we focused heavily again on access, but not enough on usability and context. Making data available doesn't necessarily automatically make it meaningful, especially for the consumer when pricing information is disconnected from the way care is delivered and discussed clinically. So it goes back to that infrastructure and standards perspective. There are a few foundational gaps that still need to be addressed. First, we don't yet have consistent interoperable ways to link clinical concepts, what a patient is experiencing or being recommended, to the billing and pricing structures behind the scenes. Without that translation layer, patients are left trying to interpret codes and data that were never designed for consumers to understand. And I think second, pricing data isn't well integrated into real-time clinical and administrative workflows. It often lives in static files instead of being accessible through APIs that could support tools and decision support or patient-facing applications at the moment decisions are being made. And finally, go back to trust and governance. It matters as much here as access. Patients and clinicians need confidence that pricing data is accurate, current, and comparable across organizations. And I think until we address those infrastructure, standards, and trust issues together, not just publish more files, price transparency will remain technically compliant, but could perhaps be functionally limited based on all those different factors.
Before we move on, is there anything else either of you would add or want listeners to keep in mind about price transparency as this proposal moves through the comment period?
The one thing, Tony, I'll add, there's another audience that people tend to forget, the employers. The employers, and when you look at the employers providing health insurance, self-insured, they're also looking at this, and they want to make sure that patients can also access the information so they can look at utilization overall. So I think making sure that when we look at this, we're looking at all the stakeholders that are involved in the process.
Janice, do you have any thoughts or comments?
I think I would encourage listeners to keep in mind that price transparency shouldn't be treated as a standalone requirement. It only becomes meaningful when it's connected to how care decisions are actually made clinically, administratively, and by patients in real time. So as the proposal moves through the comment period, I think there's a real opportunity to focus feedback, not just on access to data, but on the standards, interoperability, and trust infrastructure needed to make that data usable and reliable across the ecosystem.
Well said, well said. So I want to switch gears a little bit and spend a minute on the comment periods themselves. Participating in comment periods can be time consuming, and some organizations might have limited resources and might decide to skip it. Why is that a mistake, especially for HTI-5 and price transparency?
Tony, all comment periods are important. I think as a stakeholder, you need to be looking at how does a proposed rule or an interim rule impact you. Providing comment is absolutely critical to your business because it doesn't only impact you, it impacts your partners in the ecosystem as well. It impacts your compliance program. It impacts what you do and how you offer products and services in order to remain competitive in the marketplace. And this is key. Again, I go back to what I like to call the recipe for success in the comments. Do your research, include any research, include any of the examples that you have in your experiences, and include that data. The government does read them. They read your comments. They read what the industry and the trade organizations put together. And don't be surprised right now if they have silent listening sessions in between with your trade organizations where you'll go in, you'll be able to also raise your initial comments in a session face-to-face with some of the officials. They do listen to what is said. They won't comment back because they're in what we call an active comment period, but they do listen to the industry. So letting your voice be heard is really critical if you want to be part of the change that's going to happen here in the United States to exchange health data.
Mary, I know you commented on CMS 0057. Is that an example?
Absolutely, Tony. I think we as an industry provided significant feedback. We even worked with our clients and our customers to ensure, and we actually provide consulting to them to help them understand, now that the rule has been finalized and there's an actual implementation date that they have to hit, how these rules impact their product roadmaps and their services. So that's one example. The info blocking rule is another example. Again, price transparency is another one that is already back in 2020 been put in place. We have to look at how technology is used in order to automate and make things faster, quicker, better, and provide quality care to patients through the providers with the technology that we provide in digital health.
Janice, do you have any thoughts about this, why it's important to comment?
Yeah, I definitely think it's a mistake to skip comment periods because this is actually where policy becomes practical. And again, being able to provide input on how to operationalize these requirements, the organizations that are going to be having to do this need to be able to weigh in and make sure that it's not misaligned with the reality of what's happening in the real world. And I do agree with Mary. I mean, the work that POCP is doing to help organizations really understand how to implement CMS 0057, being able to get those stakeholder comments clearly influenced, refine timelines. They actually refine the scope and expectation of what happened with FHIR APIs and prior authorization because of the feedback that the industry came forward and put together. So I think the industry feedback helped move the conversation from, can this be required, to how do we make this achievable without breaking workflows or creating unintended consequences? So I think the same dynamic is at play with all the things we're talking about with HTI-5 and what's in and what's out, as well as price transparency. I think that's where POCP can bring the silos of an organization together and say, hey, here's what's happening. How do we actually help you address some of these issues, come up with the right comments associated with their industry and where they fit, and be able to bring real impact to be able to adjust those final rules based on what's happening in the real world and what the industry needs. Because a very complicated way to create the Internet of Health, which is where we're at. And I think POCP can bring significant guidance in what you've already been providing and what we've already seen with some of the customers that we've helped in some of these areas with the changes that are out there, especially with that foundation of trust. I think trust and governance in 2026, I think, are the two most critical words.
So the message is comment. And if you need any help commenting, reach out to us. So with every episode, we try to close with our final question. If there's one thing listeners should know or do differently starting tomorrow, what would that be? The question is usually in the context of the episode topic, but it doesn't have to be. I know each of you have industry topics that you're incredibly passionate about, so please feel free to bring up something else entirely. Mary, let's start with you.
The one thing I'm going to say is, regardless of regulation and policy, get involved, get off the bench. Get off that bench, start swinging. I come from Red Sox land, and I like baseball. You have to be involved. In order to make an impact, you have to get off the bench. It doesn't matter what the policy or the regulation is. You have to weigh in. You have to participate, Tony.
Janice, same question for you.
Yeah, absolutely. I think policy can set expectations, but it can't by itself solve the underlying standards and interoperability challenges and the trust. The conversation has to be about the relationships. And I think many of the hardest problems are in the gap between systems, how clinical concepts map to billing and pricing data, how identity and access are handled across organizations, and how data is exchanged consistently in real-world workflows. So I think we still see significant variation in how standards are implemented, even when everyone is technically using the same ones. So without shared implementation guidance, feedback, testing, governance, policy, it ends up driving compliance without guaranteeing consistency or usability. And obviously, that's why infrastructure matters so much. And I'll plug in the opportunity to get involved with FAST, because we do have a lot of the efforts of what we're working on right now for CMS-aligned networks to be able to articulate a vision that actually is executable. and being involved in the CMS Aligned Networks working groups, and then bringing that insight into our FAST working groups around how do we handle identity with the three major providers and make it easy for the consumer and beneficial for the industry behind the scenes on the data that needs to be shared for the authorization and authentication of that transaction. Being able to give consumers the ability to manage their consent at a granular level, especially given privacy rules and regulations across states and things that are happening. So being involved with associations like HL7, being involved with Sequoia, being involved with POCP, being involved with FAST and other aspects of the accelerators allows us to talk about what we need and where it's working and what needs to change. And I think that is critical for the industry to really achieve what we need to do with FHIR at scale as we go forward.
So get involved, participate, comment, make it happen. Thanks, Mary and Janice, for walking through these proposed rules with us. For our listeners, both of these proposed rules have comment deadlines in late February. This is an opportunity to shape what comes next rather than reacting after the fact. So comment. Reach out to us if you need support in crafting your comment letter or just better understanding the real-world impact these rules may have as written. If you enjoyed this episode and want to listen to our past discussions, you can find the Dish on Health IT wherever you get your podcasts and on Healthcare Now Radio. Until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.